Okay, once again, thank you for joining us on the webinar on latent TB infection. This is in honor of World TB Day. So with TB, there is a lot of acronyms. So I went ahead and made a slide here for you that shows all of the acronyms that are going to be in this presentation. Hopefully you got the PowerPoint before this presentation began. So if you want to print out this page, certainly you can. It might help you as we go along. So first, a quick overview of the difference between latent TB infection versus TB disease. And this is really important. Sometimes people confuse the two if you're not too familiar with TB. So latent TB infection, the TB germs are dormant, and this phase can really last for decades. The patient will feel well, and the chest x-ray is typically normal. This patient is not infectious at all, and it gets treated by taking 1 to 2 drugs. Now, with active TB disease, which we're not talking about today, the TB germs are reproducing and spreading and causing tissue damage. The patient is sick. Typical symptoms include a cough lasting more than 3 weeks, weight loss, night sweats, and fever, and you need to get a chest x-ray and some other tests like sputum. So this person would be infectious if it's pulmonary or laryngeal, and you treat active TB disease by taking 3 to 4 drugs for at least 6 months. So today we're going to talk about latent TB infection.
Yeah, and I'll just mention too, I mean, we've drawn those two distinct categories of latent and active, but as you know, it's really a spectrum, and all TB is really kind of active. It's a persistent infection, and yes, it may be like very, very inactive, like really rarely active, and your immune system, takes care of it when a couple bacilli double here and there. But it is alive. Now, there are people that have extinguished their TB and don't really even have latent TB, but just so you know, latent TB is a dynamic state, and it just happens to be that people aren't sick and cannot transmit at that point. So Heidi and I are just going to tag team this up. So, who should be tested? I mean, clearly people at high risk for TB are the target. So, the most important of the people have just been identified as contacts. So people who are recently potentially exposed or infected, they're at the highest risk for reactivation in the first 2 years. So that's really one of our primary targets. The other primary target is, of course, people who have risk factors for exposure, but who also have risk factors for progression to active TB. So immunosuppressed conditions, which we'll get into. But in general, the U.S. obviously the risk is so low, we don't target the general population for testing. So risk factors, I mean, in Oregon, by far and away, the biggest risk factor is immigration from a high burden country. And that's true nationally, of course. We have 75% of our TB or even higher in some places is due or is occurring in people from who immigrated from outside the country. Other risk factors of exposure, of course, identification as a contact to someone with TB disease. Patients who've had a history of TB and they have abnormal chest x-ray. When we say abnormal chest x-ray, we're not talking about granulomas. We're talking about upper lobe fibronodular kind of reticular infiltrate or scarring. Those are the people that are higher risk for reactivation. It's because a lot of those people have very small amounts of active TB or transiently active TB. And those are the folks we often see as B waivers or other screening. Other patients being screened, and you see that, and the trigger should be to get sputum. Even if they're asymptomatic, we often get sputum anyway. Residents, employees of congregate settings. I don't know, Heidi, are we still really focused on those folks in Oregon? Maybe just
Not
upon
as much.
entry, but not not after entry to those settings, I believe. So.
Yep. No more annual testing.
And lastly, the other risk factors for progression. I mean, anything that suppresses your immune system. So HIV and AIDS, this is still an issue, although not as much an issue here as it is other places in the world. IDU, injection drug use, this is kind of an old thing that's been, on the list forever, but it's not really a risk factor for progression. It's a risk factor for exposure, particularly because that kind of drug use is associated with homelessness and incarceration. It's also traditionally been a risk factor for HIV as well. So, and it is one. So, I mean, those type of people maybe are more likely to have immunocompromising conditions or prior exposure. Diabetes is certainly a risk factor. The poorer controlled it is, the higher the risk. Biologic drugs such as TNF blockers, steroids is a big one, and other malignancies and renal failure. We often talk about gastrectomy and things like that. I mean, there are certainly people that have those histories. They're fairly rare, but that is an independent risk factor. And then weight loss. It's hard to know sometimes if the weight loss is preceding the TB reactivation or associated with it. The answer is both. There's no question that weight's a huge player in this. And as you lose weight, you lose your Th1 immune responsiveness, essentially, to some degree. I mean, that's what we think is happening, and so TB is more likely to progress.
Thank you. Okay, so here's a question you can think of, and you can put the answer in chat if you want, or you can just think about it. So recent CDC guidelines recommend stopping annual TB testing of healthcare personnel, and hopefully you guys have already gotten this message. If thinking about this change in terms of risk factors for TB, why did CDC make this recommendation? I think Kevin already talked about this a little bit. And secondly, if during your annual TB education at your hospital, you have a healthcare provider who comes up to you and says that they recently returned from mission work in Ethiopia, what would you do? What would be the practice in your facility in that scenario? So if you like, put your answer in chat. Okay, maybe it's not chat. Go ahead and put it in question. I don't think, I see that some people already put things in questions, so go ahead and put it in the questions box. I hope so too. Okay, all right, looks like we don't have anything much yet. So I'll just go ahead and run through this. So basically, like Dr. Winthrop said, you know, Oregon is a low risk area for TB. It's gotten to be lower and lower risk over the years. So we just don't really have that working in a healthcare setting as a risk for exposure any longer. So that's why annual testing was stopped. If somebody comes up to you during your annual TB education and says that they had a risk for a new exposure, then yeah, absolutely, you should try to get them tested. Hopefully you have that capacity in your facility to do that. Okay, so I see there is a question. It says, what if working in settings with refugees chronically? So I guess your question is whether or not you should do annual testing if you see refugees, maybe?
Yeah, I mean, I think it depends on where you are in the world. If you're here working with refugees coming in, you know, your risk is, I would still say, it's pretty low.
I think so too.
Particularly given those people are being screened, and presumably active TB cases aren't necessarily showing up very frequently. So I would say, you know, if you wanted to do annual screening, that seems pretty reasonable to me. I mean, that's kind of what we would do for, you know, someone working in a jail or something in a high risk setting where there is potential ongoing exposure.
Okay, on to the next one.
But still, it's pretty low risk.
Pretty low risk, yep. All right, now a little bit about diagnosing latent TB infection. So just a little bit about LTBI in general. The TB skin test and the IGRA, that's the T-spot and the quantiferon tests, they both reflect immune sensitization. So they're not direct proof of infection. And I think this is an important point. And sometimes people get confused about this. LTBI is relatively common. It's that 33% of the world's population is infected. Most countries actually don't test or treat for LTBI right now. They just don't have the resources to do that. We think that some people who inhale TB likely clear the infection and have no live germs. Do you think that's true?
Yeah, that is probably true. It's hard to do that study. So I mean, we all think that that's true, but we don't know.
We don't know, right? Good point. So, probably about 5 to 10% of people with LTBI go on to develop TB disease. And the TB skin test or the IGRAs cannot be used to diagnose TB disease. A lot of times they'll actually be negative because that person's immune system is just overwhelmed fighting the TB disease. When we look at our cases of TB disease, about 50% actually have a negative quantiferin or negative T-spot, so a lot of negative tests. We know that these tests for LTBI aren't perfect, and I think there's been a lot of work right now to improve all the tests. Well, maybe not the TB skin test, but the other tests.
Yeah, the new, I don't know, the T-spot and the quantiferin are both pretty similar. The newer platform of the quantiferin, the plus, I mean, it has this extra CD8 tube. We actually did the sensitivity and specificity studies for the FDA submission. So, I mean, sensitivity was 93% active TB, which was pretty.
That's good.
Which was pretty good. And the specificity was just the same as the old test. It was 98%. So, I mean, I think that both the T-spot and the quantiferin are very comparable. They do the same thing or accomplish the same idea. And they do appear more sensitive and specific than the skin test. So I think if you can use them, it's usually the preferred test, although in some cases it probably doesn't matter which one you use. So.
Yep. All right, so we're going to quick review the TB skin test. Do you want me to just quick run through
Yeah,
things?
do the run through, because I can't remember this.
Don't use TB skin tests anymore. All right, the TB skin test, a lot of people measure it wrong, so there's a little diagram for how it should be measured. So what should you do if somebody comes up to you in a healthcare setting or another setting and they tell you they have a prior positive TB skin test or IGRA? You need to have documentation of that positive test result and a negative chest x-ray. And then in the healthcare setting, you don't want to repeat that test. You can just go ahead and screen them for the signs and symptoms of TB at that point. They would be cleared. Now, there are some exceptions to this. Say you want to at some point treat that person for a latent TB infection because they weren't treated in the past. If they had like one of the older generations of quantiferin or a TB skin test, you might want to do a new IGRA. So use the newer version of quantiferin, for example. And then all are going to need a new chest x-ray before you start treatment. And then, of course, if the patient has symptoms of TB disease, you want to go ahead and get a chest x-ray and probably sputum too. So a little bit about administering the TB skin test. You can see the diagram there, but just a couple of quick points. You don't want to drop the solution more than a half hour prior. Don't put it on any scars or tattoos, anything like that. You let the cleaning agent dry before you do the injection, and you need to produce a wheal. If you don't produce a wheal, you need to put it again in the next arm, and don't put a Band-Aid on it. Kevin, what do you think are some good alternate sites if, say, somebody has tattoos all over their arms?
Wow, I don't know. I've never had to go beyond the arm, but I would probably do an IGRA in that case.
Yeah, that's actually the best solution is to do a blood test, right? Right. Yep. I've heard you could maybe do like around the scapula or something like that.
I guess you could. It seems to me the lower extremities, it would be too thick, I think, skin-wise.
Yeah.
I don't know. I don't know that you could read it the same way.
Yeah.
I don't know. I've never heard anyone doing that.
Yeah. Okay, so what if you mess up when you do the TB skin test? All you do is repeat it, or like Dr. Winthrop said, you could do an IGRA instead. Just place another TB skin test immediately on the opposite arm and document where it's placed. No biggie. Okay, now a bit about reading the TB skin test.
Yeah.
Okay, I'll carry on.
Sure.
So tips for reading the TB skin test. You want to read it 48 to 72 hours after placed. And you can read it up to 7 days later if it's positive. So only if it's positive 7 days later. Remember, the patient can't self-read. You can't just give them the card and say, call me if you have a bump. That's not allowable. You want to measure across the arm, transverse, and then record in millimeters, even if negative. Again, you need to measure the bump and not the redness or the erythema. So a couple little tips. You can use a pen to mark the margins. That's what I used to do. Kind of hold the arm up and get the light across it and look from side to side to see if you see a bump. You can use your fingertips always to feel the surface. You want to always feel the arm to see if anything's there. And then if you're still not sure, look again the next day. Some people have a delayed response and they're actually going to have a bigger test the next day. And then, if you need to, just go ahead and repeat it. And probably if you need to repeat it, an IGRA is the best way to go.
Yeah, I like the pen too. That's what I usually did. But I mean, it's interesting. We all, everywhere in the world, we measure in duration, except for Japan. They measure erythema.
Really?
Yes, yes, they do. So, yeah, there's probably something to it, but stick with in duration for now. That's our guidelines.
It's funny. Okay, so here you go. That's the correct way to measure it and the wrong way. So a lot of times, and this is one of the problems with the TB skin test is people don't come back for the read. So you want them to come back in 48 to 72 hours. You don't need to be super obsessive compulsive about that 48 to 72 hours. So we just say give or take 4 hours or so. And again, if it's positive, you can read it within 7 days. If there's no reaction and more than 72 hours have passed, you need to repeat the test. And again, if you need to do a new one, do it on the opposite arm. All right, questions for you. Is the TB skin test easy to read and interpret? What do you all think? Think about that or put it in the question box. And the second question is, in the future, it's likely we'll no longer use TSTs. Is that true or false? Oops. Okay. Looks like we have a true and a false here, and I'm on the wrong slide. Okay. All right. So the TB skin test is easy to read and interpret. I would say actually false, in my opinion. A lot of times it can be hard to read a positive test, especially like if you're reading it for a contact, I've found. It can be hard to read because you're just looking for a millimeter,
Yeah,
5 millimeter.
super small.
Super small, yeah. In the future, likely we'll no longer use TSTs. That's true, I think. What do you think?
I think it's true. Depends where you are in the world, but yeah, it's hard to imagine that we're still using them.
Yeah, I know.
in some ways, so I can understand if you need to because you don't have an option, but blood tests are better tests. So
yep, I think they're gonna go away. Okay, a little bit about TST positivity, and I'm just going to run through these really fast. So that's the list of greater than 5 millimeters. That would be a positive. I think most important for us is this includes recent contacts to somebody with TB disease, so don't forget that.
We go back to, that's a good x-ray though. That shows that kind of upper lobe reticulonodular kind of scarring type pattern, that fibrotic chest x-ray. So that's the x-ray that we are most concerned about in terms of risk factors for progression.
Yeah, exactly. All right, so 10 millimeters and greater, here's the list. Most importantly is all immigrants from high burden countries. There used to be it had to be immigrants who came within the last 5 years, but we changed it, so it's all immigrants. And then those other things there. And then 5 millimeter or 15 millimeters and greater, probably you didn't even want to test this person. And just a reminder that for healthcare personnel, the cutoff is 10 millimeters, not 15. So we have these rulers available for you if you want. Just contact me and we can send you as many as you want. They're nice, they're plastic. We're happy to give them to you. Okay, a new staff person taking Remicade is given a TB skin test. The result is 5 millimeters. Would you consider that a positive or a negative result? You can put that in the chat or in the question box if you want. And then just something to think about. In your clinical setting, do you ask questions to determine risk factors and immunocompromised status when you're doing your TB screening? Okay. Correct. So I see somebody said that should be a positive test if the person is on Remicade. Would you agree?
Yeah, a
Yeah.
strong risk factor. I mean, it's probably the strongest of all the TNF blockers. It is the strongest with regard to TB risk. So all of those drugs carry risk, but that etanercept carries a slightly lower risk than the other ones. But the other monoclonals, which Remicade is one, they carry the highest risk. I'll also say there's a whole lot of other biologics that we don't have time to go into, and there's JAK inhibitors. There's other drugs that carry probably similar or somewhat lower risk, but also screening is warranted. The second bullet, I don't know. Do you guys do that? Do we have any answers? I think you have to.
Yeah.
I mean,
Yeah, we
all
have to.
about the way to interpret these tests is applying your perception a priori risk of either exposure or risk of progression if they have been exposed. So you got to use those two concepts somewhat separately, and then think about them separately, and then come up with a combined estimate of do I think this test is right or not.
Yep, agreed. Yep.
So
you need to do it. Every once in a while I get asked, do we have to do it? And the answer is yes, you should.
yeah, and this is important too, false negatives. So I mean, I see a lot of folks in the rheumatology setting, pre-biologic, things like that. Actually, I saw one today who was on a biologic for 2 years and never had been screened. I don't know why, but someone thought about screening her and she's positive. So now she's off of biologic, and I'm starting her INH RPT, 12-week regimen today. But you really worry about false negative results. And if you look at most of the trials where people have screened people prior to immunosuppression or during immunosuppression, I mean, most of the people who end up with TB are people who screen negative. The positives who screen get treated, so they don't develop TB. So, I think most of us think that most of those negative screens are false negatives because they're immunosuppressed. So, there's really two issues. One, what are the risk factors for exposure, and how immunosuppressed they are? And if they have risk factors and they're pretty immunosuppressed, and you have negative, I often repeat it because I don't believe it. And we can talk about that more later. But certainly HIV, if it's not well controlled, if they're already on immunosuppressive drugs, if they're old or if they're super young, other concurrent infections or illnesses. I mean, these are all reasons why people might have false negative skin tests or blood tests. False negative results or anergy, that's what we call this. Sometimes the skin test is weird. I mean, I've placed one on one arm before and put a different kind on the other, and you got different results. I mean, people have done those studies. Some of the discordance there, or just some of the false negatives and false positives, have to do with contamination of the tuberculin, or batch to batch variation, improper storage. And certainly how it's placed. Was it placed too deep in the arm, for example? And then the reading, which can be quite variable depending on who's reading it. So all these factors come into play with interpreting the skin test. False positive results also occur mainly from BCG. That's the big one. We think somewhat also due to non-tuberculous mycobacterial. That's a hard thing to measure, but there have been studies with PPD and as well as MAC antigen, or the BADI antigen, where they put them into people simultaneously. I mean, certainly people who react to the BADI avium antigen were more likely to react to the PPD or TB. So, I mean, there is some cross reaction. I think that's been well documented. Sometimes people are allergic. Usually they're not, though, and they say, "Oh, I had a big allergic reaction," and they'll tell you about this huge bump that was really not comfortable at all, where they got their skin test done. And almost all those are positive tests. Those are not allergies. If it's an allergic reaction like Heidi has here, I mean, usually it should go away, very quickly. Something that's large, red, warm, and uncomfortable for a few days, that's a positive test. So my experience is almost all those are positives.
Okay, so this little bit is about how you should document your TB skin test. Of course, like we said, you need to do an assessment for signs and symptoms and risk factors first, and then you would just put the date the TST is given, the date it's placed, who put it on there, who administered it, the arm it's on, and then the lot number and expiration date. So this documentation is really critical. You always record it in millimeters, and you record it as positive or negative. So a good example could be 2 millimeters negative. So that's how it works. You always want to give the patient a copy of the result, especially if it's positive, and tell them not to lose it. Keep track of it. All right, here's a little scenario. This is kind of what Dr. Winthrop was just talking about. A patient comes back for his reading. He tells you he was moving this weekend and had to carry boxes. It messed up his TB skin test. You look at his arm and it looks something like this. So people can go ahead and put an answer in the question box what you think you would do.
Answer in the question box.
Yeah, I know.
Counterintuitive.
It is counterintuitive. I see a repeat test, okay. Somebody else says measure it for induration. All right. So what do you think you would do if this was your clinic? Well, you don't do TB skin tests, but pretend like you did.
Yeah, I'd probably do Niagara. No,
Yeah.
it's probably a positive test. I mean, if the guy had risk factors and this was his result, I would say it's probably positive. Now, if the person didn't have risk factors and this was the result, then I would repeat it, either a skin test or a Niagara. That's what I'd do.
Perfect.
So you mentioned, you noticed my answer was all about risk factors. I mean, it's really, a priori probability is such an important thing. So
Absolutely. Okay, do you want to explain this?
Yeah, I really like this box. Colleagues who published this was a recent guidelines for LTBI evaluation. I think was it last year? I think it was last year. I don't know. In this now COVID time period, I can't remember what year we're at, but I think it was about a year ago. And the thing that was nice, really the update here in the document, was that for the first time, CDC distinguished between those two ideas I mentioned before. You have the idea of what is your risk of exposure, and it's a very separate concept than what is your risk of progressing if you've been exposed or if you actually have latent TB. And those are two separate concepts. And previously, CDC always blended those together, like HIV is a risk factor. Well, HIV is not a risk factor for exposure, but it is a risk factor for progression if you have TB. So that's a good example. And so what they did in the new guidelines is they finally separated those ideas and they came up with this box. So, I mean, the group on the left in the red is really those people that are likely to be infected, but they also have a high risk of progression. So they come from Vietnam, for example, and they have HIV. So this is a group that is likely to be infected and likely to progress. So you use your lowest threshold for the TST, the 5 millimeter, and really in this group they say a TST or an IGRA is acceptable. Although if the person has had a history of BCG, of course, the IGRA would be preferred. In other settings, go to the bottom, the blue one. If they're unlikely to be infected, you're probably not going to be testing them, which is what their testing strategy says in bold. Testing for LTBI is not recommended. But if you really have to, the IGRA would be preferable given its increased specificity. The middle box is kind of the usual. I mean, this is a lot of the people we screen. They're likely to be infected, but they don't really have a risk of progression. And actually, I take that back. That isn't a lot of the people I screen. I screen mostly the people in red. But these people do get screened. And, say, for example, a foreign-born healthcare worker that doesn't really have a risk of of progressing. They're healthy otherwise, but they are likely to be infected. Well, the IGRA is preferred in this case due to the specificity issue mainly. So anyway, here you have this box. They basically prefer the IGRA in all these situations except for the top where it probably doesn't matter because they're really going to probably be positive on either one. But I think in general, most of us have kind of swapped over to an IGRA. We're doing both, in that kind of situation if the person's immunosuppressed, for example, and you feel like you can't trust either test. So.
Okay, I think we just already kind of went through this, but basically IGRAs are preferred when the person's likely to be infected and low to intermediate risk for progression. or unlikely to be infected, like Dr. Winthrop was talking about, like healthcare worker screening, or BCG vaccinated. TB skin tests are still recommended in general for little kids under the age of 2. And then you probably would maybe want to do both an IGRA and a TB skin test if the result is really critical and the person is immunocompromised, or you have an interpretation of a TST or IGRA that's not clear.
Yeah, I'll just add too, in kids. I mean, I think if you really want to know, you should do both of them. I mean, if they're that young, because none of the tests are sensitive enough to make you feel good. Just as none of the tests are sensitive enough in someone who's taken 30 milligrams of prednisone a day. So doing both of them, or doing one and repeating the same one sometime later, or some sort of dual test strategy is probably better given the sensitivity concerns in those groups. There it is, the T-spot and the quantiferon plus, as they say in France. Plus. T-spot has some advantages. It's one tube only. The labs don't really do it. I mean, that was why it wasn't quite widely adopted initially, but there are now reference labs doing it, so it's pretty easy to get done, I think. Whereas 10 years ago it wasn't. So now you can, you can certainly test people and just send it through Quest and get a result. So I think it's pretty easy. As I said, I think it's very comparable to the quantiferon in terms of, the test characteristics. The one thing that is different here is there's kind of this borderline group in the T-spot that doesn't exist in the quantiferon. I don't know that the borderline is very helpful. To me, it's kind of like just getting a borderline quantiferon result, a result that's kind of on the border of positive to negative. So, but suffice it to say, these tests are out there, and I think they work well. So it's a good choice. The next one's the quantiferon, I think, probably, and I don't, other than this being easier for labs to do, so it's probably more widely offered, outside of reference labs. I guess one disadvantage is maybe you got to put it in 4 tubes. There may be some other advantages there. You get a little bit more information back with the second tube. There's the difference is they took an antigen out of the tube from the quantiferon gold, so now they just use ESAT6 and CFP10. They took out 7.7. And taking 7.7 out didn't really affect the sensitivity at all. In fact, sensitivity is probably slightly better than the old version, or at least as good, but it is actually slightly better. The reason why it's slightly better is that second tube, where you're measuring both CD4 and CD8 responses, as opposed to the old test, as well as the TB1 tube here, where you're just measuring CD4 T cell responses. So having that second tube probably buys you a little bit of sensitivity. If you're strongly positive on both tubes, boy, to me, it's almost like having two tests that are both positive. I think it increases your a priori probability that's really a true positive. The way the test is run, though, is either tube positive is considered a positive. So
great. Okay, we just talked about that, so we won't go through that again. But
yeah, the only thing I'll say here is indeterminates. You do see those. Some people get frustrated by them. Kind of 5% or less, depending on the immunosuppressed group. You do see sometimes higher if they're really, really immunosuppressed, but mostly in the biologic realm. Most of the usual settings of immunosuppression is kind of a 3 to 5% indeterminate rate. All I can say is just repeat the test, and if you want to repeat the same IGRA, or you want to pick a different IGRA, or you want to do a skin test, you could. Any of those are valid strategies.
Cool. Okay, definitely you can have false positive IGRAs or TB skin tests. That's why you need to do a risk assessment for everybody. And then if you're skeptical of the result, you just want to repeat the test unless there's a high risk for disease progression.
Yeah, I don't think you can ever go wrong repeating.
No.
I repeat tests all the time. It's what we learned in med school. If you don't believe it, repeat it. If it's really positive, it should be positive again. I mean, unless something's changed in the patient, which is sometimes the case. So you do have to sort that out. Like, did they change their prednisone dose? Or are they not immunosuppressed now and they were before? Or they're more immunosuppressed now than they were before? Things like that. So.
Okay, you test a patient with a quantiferon. When she comes back for the results, she brings documentation of a positive TB skin test. But what? The quantiferon is negative. So what would be some reasons why this might happen? You guys can put your answer in the question box. Okay. All right, we'll go ahead and go through this one. So basically, if the patient was, say, BCG vaccinated, she might have had a positive TB skin test in the past, but now she's getting the quantiferon and it's negative. So that would probably be the most typical reason.
Yeah, that's pretty common.
Yeah.
I mean, other options are, it's real and it's been 10 years and she's allergic now.
Sure, yeah.
Again, it kind of comes back to the risk factors. And if the person has no risk factors, you are more likely to think that they're truly negative than if they do have risk factors. So.
Yep, totally. Okay. Okay, quickly we'll run through these special populations. Let's see. You have a new patient who was born in Thailand and she arrived in the US 10 years ago. She was diagnosed with rheumatoid arthritis and has been on prednisone. You want to switch to Humira. How will you test this patient for latent TB infection? How will you proceed and what are some of your concerns? So what would you do in your clinic with this patient?
Yeah, I mean, presumably she should have been screened before she was put on prednisone. Of course, that usually doesn't happen, but I'm a big fan of that if they're going to be on chronically, of course. You could also say, well, if they're on prednisone and they haven't reactivated by now, what's the risk with Humira? That being said, that's a reasonable idea, but there's plenty of people that reactivate even after having been on Humira for 2 years. All of a sudden, they reactivate. So whenever the time's right, TB tends to just decide to reactivate or progress. This kind of patient, I would probably try to take them off their prednisone or wean them down to the lowest dose possible, and screen them prior to starting the adalimumab. And I would use an IGRA, and I would probably repeat it if it was negative, or I'd use a skin test and an IGRA. I mean, they're from Thailand. They probably had BCG, but they're at a high risk probably for being previously exposed. So I would probably use kind of a dual IGRA approach in this patient, since they're on prednisone. If they're not very immunosuppressed when you find them, you may not have to be as aggressive of screening. But certainly she has risk factors, so I would anticipate her to be positive.
Perfect. Thank you. So here's a little bit about the TNF alpha inhibitors. Well, we're running short on time already.
Yeah, you guys know these.
Yeah. So this is just the general method of what you would do, I think. It's still the same.
Yeah, and I can just tell you, I mean, my patient today, she stopped her etanercept. So as soon as she starts her LTBI therapy, which should be tomorrow, she can resume her etanercept. So really with the TNF blockers, we used to kind of wait this month. It was a magical month from the Spanish study 10 years ago. But in reality, all you need to do is start your LTBI treatment anytime before you start or resume the TNF blocker. So you don't have to wait, but I do think waiting a few days or a week just to make sure they're taking their LTBI treatment is a good idea.
All right, so TB case contacts. First, you have to figure out if the person is indeed a contact, and there's some parameters you can use for doing that. So when and how to test contacts, you test them immediately after exposure and then 8 to 10 weeks later. We really prefer the IGRAs, although a TB skin test is okay. You want to make sure, though, that you stick with the same testing method for each test. So you also need to be aware of any high-risk contacts. So that's people who are immunocompromised or kids less than 5. For those folks, you maybe want to get a chest x-ray and also consider window prophylaxis. So when you're doing a contact investigation, you're almost always going to run into somebody who had a previously positive TB skin test or IGRA. So first of all, you can't just take their word for that. It needs to be documented. If they didn't complete treatment in the past, now's a good time to offer it. And of course, you want to get a new chest x-ray in that case. Generally speaking, if they were treated previously and they're now a contact, we only do a symptom check unless the person is immunocompromised or a child. Okay, I think I'm going to skip this one in the interest of time, but you guys have the PowerPoint and you can look it over. All right, moving along to treating latent TB infection. So, what is my risk? What do you usually tell people their risk is of breaking down a TB
You know, I
disease?
usually tell them it's 5 to 10%,
Mhm.
and almost everyone's in the 5% or less.
Yeah.
Unless they're in that first 2 years. So, obviously, that is your healthy person who's not on any drugs and doesn't have diabetes and doesn't smoke. And once you start adding some of those things, then I think you can start increasing the risk. What's the risk of someone on infliximab? And they got infected 10 years ago. I don't know. Is it 10%? It's probably doubled by the infliximab, something like that. So maybe it's 15 or 20%, or maybe it's even higher. So, so we don't know exactly, but I do tailor that risk estimate based on those risks, whether they have risk factors for progression.
Excellent. Okay, so you always need to rule out TB disease before starting latent TB treatment. That's really important. So you need to check for symptoms of TB disease and get a chest x-ray. For adults, it's just a PA chest x-ray. For kids, it's a PA and a LAT if they're less than 5. And then typically, I don't know, if a chest x-ray is more than 3 months old, you might want to get a new one.
Yeah, I mean, our rule of thumb in California, we were there at the TB clinic at the General when I worked there. I mean, it was 2 months. That was our rule. So I've just kind of kept that with me forever. I mean, obviously they're symptomatic, it's different, but if they have no symptoms, I mean, I think 2 to 3 months seems reasonable. I use 2 months still to this day. So.
All right, so there's no age cutoff for treatment. You need to look at the risk of disease progression versus treatment toxicity, I think.
Right.
All right, let's see. Okay, so you work in an employee health at a large hospital. 2 weeks ago, a patient came into the ED with a cough. His chest x-ray was abnormal with pulmonary infiltrates. He was diagnosed with pneumonia and sent home. This is kind of typical. When his chest x-ray didn't improve, his PCP collected sputum to find out if he had TB disease. At that time, his sputum was smear plus 3, gene expert positive for TB, and his cultures are pending. So you know you have a case of TB here. If this was your facility, what would you do, and how would you decide who to test, and what test type would you use? So you can take a minute and put that into the question box. And this kind of thing happens, right? I think it happens at the best hospitals. You can't just,
all the time.
Yep, you just can't catch every case. So. All right, so we know this patient is relatively infectious because his sputum was smear plus 3, so you have that. Usually what we end up recommending is that you start with the healthcare workers that had direct contact with the patient.
Yeah.
So probably that's who you want to start with, and then we usually recommend using IGRAs. So.
Yeah, and if you see transmission in the direct healthcare workers, then of course you call people like us in the county or whatever, and you make a plan between all of us of where do you draw the line? What's the next concentric circle? Who else to test? I mean, usually it's the household, and usually it's the direct healthcare workers and something like this. And usually we don't go beyond that, right?
Not
I mean, I think
often,
it's pretty rare that we have CIs that then we got to start thinking about testing, patients and other people who are in the area that weren't directly working there.
Yep, exactly. Okay, we'll skip that one. Well, okay, well, maybe we'll do it. All right, so the nurse who saw the patient during the visit is a 65-year-old healthy male with no risk factors except for the recent exposure. He tested quantiferon positive.
Yeah, treat him.
10%
risk.
Yep.
Reaction, and plus they're a healthcare worker.
Yeah.
So there's a lot of reasons to treat this person.
Yeah, you don't want them breaking out with TB disease, that's for sure. All right, a little bit about LTBI treatment in some special populations. Do you want to run through these?
I love that.
I know.
Yeah, kids. I mean, the younger you are, the more likely you are to benefit from treatment. So we almost always treat kids. I mentioned the lady I started today. She started on 3HP or 12RP. Well, I don't know. We've got several acronyms, but the once weekly, 12 weeks isoniazid rifapentine regimen. it's probably our most preferred regimen, that or rifampin alone for 4 months. I think either one. I mean, rifampin alone for 4 months is probably the safest of all regimens. It's probably equally as effective as 3-HP. However, there's a lot of drug-drug interactions with that. So you kind of have to, actually the patient I had today was a great example. I mean, she had 3 drugs that interacted with RIF, and I just thought it was going to be a little too tough to treat her with RIF alone. And 3-HP, at least the rifapentine's only there for about 36 hours. So those interactions will only exist for about 36 hours each week if she remembers to take it. So I went with 3-HP. But I think those two are really where we've gotten the last few years. And then INH rifampin daily for 3 months. That's been added more recently by CDC as also a preferred alternative. So all 3 of those rifampin-based short course regimens are really well tolerated. They're safer and they're as effective or more effective than 9 months of INH. That is your alternate. I still use it sometimes in people, particularly if they have a lot of rifampin-based issues they can't deal with. Usually drug-drug interactions, but it's important. That's always there. I don't ever recommend 6 months of INH. I see Heidi doesn't have it on her slide. I'm happy. I don't think there's a reason to do that. So.
Okay, great. Okay, we will skip this because we are running behind a little in time. So LTBI treatment in pregnancy. So typically you don't want to get a chest x-ray in the first trimester unless the person's HIV positive or recent contact. You just wait until the end of the first trimester. And then you want to do a shielded chest x-ray. That's still pretty much standard practice. And you would only start treatment again if the person is HIV positive or recent contact. If somebody becomes pregnant while they're on treatment, you just go ahead and stop. Which regimen would you use if you needed to treat somebody who was pregnant?
I mean, I would use it's kind of hard. INH might be safer slightly. I mean, both of them are, I forget which class they are, class B or C, I don't know. I mean, both of them have really low rates of teratogenicity or birth defects. And I mean, I think they're drugs we're comfortable using in pregnant women. I mean, it's usually in the context of active TBI. Active TB. We use them all the time. So I think either one would probably be fine. I tend to veer towards INH actually because I think it has a slightly lower risk of, or at least documented rates of teratogenicity. So I usually talk it over with the mom. It's a shared decision-making thing, but it's rare that we have to treat people for LTBI when they're pregnant. It's really just advanced immunosuppressed individuals or recent contacts where we do that. So
yeah, perfect. Thank you. So older people, I think this is a common question. What do you usually do with older people as far as treating them?
Well, that lady today, I mean, she was 75.
Yeah.
I'm not sure I would have treated her. She immigrated here 30 years ago from Vietnam. The only reason I'm treating her is because she's going back on etanercept. I think probably other than that, she had no risk factors. I probably would have let her ride at that point. The short course rifampin regimens do change, or rifampin-based regimens do change the way you think about it. I mean, if you can treat someone in 12 weeks, you're much more likely to offer it to a 70-year-old than 9 months of INH, for example. So I have found myself treating older individuals the last few years because I've really drifted towards rifampin-based regimens. So
cool. All right, we're going to skip this one in the interest of time. So now we're going to go on to the LTBI drug regimens. So, like we were saying, now you have quite a few options available to you, and they're listed all on this table. So, rifampin, I think it's kind of a preferred regimen right now. The regimen is 4 months daily rifampin, 600 milligrams. Comes to 120 doses. Well tolerated by most people, as far as I can tell. And it's appropriate for kids of any age, which is exciting. So that's easy for them to get through. And of course, you don't want to use it if there's any chance you're going to have unmanageable drug interactions.
Yeah,
I think
that's a big issue. But also tell people, remind them their urine's going to turn orange or red so they don't freak out and think they have blood in their urine. So I always remind them.
Another one is 3HP, and this is the one that's 12 weekly doses of INH and rifapentine. DOT, or directly observed therapy, is not required, but there is higher completion rates with the DOT. Do you find that it's pretty well tolerated? Because I hear mixed things about it.
Yeah, I mean, I do have. It's funny. This is just anecdotal, so take it with a grain of salt. But my experience is just kind of the older individuals do fine with it. It's younger people, who are, I don't know. It's variable. There is maybe 10% or 15% of people that get bothered by the rifapentine, I think, and they just get some fatigue from it. Usually it's some fatigue, and they don't like that. And so I don't know, but most people I'm treating are immune suppressed, and I think they're less likely. They're already fatigued. I think that's so. I don't know that they feel any more fatigued, but I think it's highly tolerated, as per the phase 3 trial, and I think with some post-marketing data. So I think it's a great way to go. I really like it, and for me it does help with some of those drug interactions, because a lot of them, for example, I mean, if it's like it interacts with your Lipitor, big deal if your lipids, aren't managed as well, 1 day a week because of this drug interaction. So it depends what the drug interaction is, but some of them are pretty minimal when you think about the time involved. So
Yeah. Yes, I think some of the problems with the regimen is we've had issues where insurance doesn't cover it, or there's shortages with rifapentine, and also it's a lot of pills for the patient to
yeah,
take.
the pill burden is huge. I mean, the lady today was 12 pills, so she was not that psyched about that.
She didn't want to choke them all down.
Yeah, I guess it was 9 pills. I guess that's what it was. 3 INH and 6, RPT, plus a vitamin B. So,
Yeah, it's a lot. Okay, so completing treatment with 3HP, ideally they should get in 12 doses, but 11 weekly doses is acceptable. You want to try to give the doses at least 72 hours apart, and definitely no more than 4-week interruption in treatment. Like we said, here's a few reminders. Lots of drug interactions. It's going to stain your tears, saliva, and urine, which we already talked about. Hepatotoxicity is possible, but less than INH. And then also thrombocytopenia is a possibility. So you need to make sure that you're watching out for easy.
Yeah, I mean, I use rifampin all the time between TB and NTM, and we just had this debate on email. I mean, I don't think I've ever seen a case where rifampin-associated hepatitis.
Really? Yeah.
I mean, maybe just, okay, one in 15 years. I mean, it happens, absolutely, but it's pretty unusual, and we use it in our liver-sparing regimens. Cytopenias are much more common, and then, also rare, but I've had a couple patients develop interstitial nephritis, renal failure. So very, very unlikely, but it can happen.
Okay, LTBI treatment with isoniazid. This is not our preferred regimen anymore. It's an alternate. So that regimen is 9 months of INH 300 milligrams daily. We don't really like the 6-month regimen here, so try not to use it. You should probably add vitamin B6, 25 milligrams. I don't know, for most patients. I don't think it really harms anybody. You don't really need to do baseline labs necessarily, but if they have any risk factors for liver problems, yeah, you'll want to get LFTs before you start. All right, so you have a homeless male that was exposed to TB in a shelter. He's quantiferin positive. He reports drinking a 6-pack of beer daily. Do you think you should treat him for latent TB infection? And if yes, which LTBI regimens might be best? So you can go ahead and put your answer in the question box. So we have some other questions here we can answer while waiting. So why not 6 months INH, do you think?
Yeah, this is an easy one. Well, you already heard Heidi say rifampin-based regimens are your preferred regimens, and certainly with this guy's liver, which is probably compromised based on his alcohol intake, a rifampin-based regimen would be probably better. 4 months of rifampin is 1 extra month compared to your 3 INH rifapentine. The hepatotoxicity with INH rifapentine is certainly less than 9 months INH. I think it was about half in the study, if I remember right, but it's still substantially higher than rifampin. So you could pick either one, but I think if you think you can get this guy to do rifampin, I'd do it for 4 months. If you can't and you need to do like some sort of directly observed therapy, like here's the only way you can get in the shelter this week is if you take your pill, when you show up that day.
Yeah.
I mean, maybe that kind of strategy would work for the other regimen.
Yeah, great. Perfect. So we have a nice little LTBI regimen reminder card, and if you are interested in getting these cards, contact me. The backside lists the various regimens. They're a good reminder for providers. All right, a little bit about side effects. When you're in doubt about a side effect, always stop treatment. It's always okay to stop. It's not a big deal. So monitoring while the patient's on treatment, you want to evaluate monthly for adherence. So you want to do a pill count if you can. And then you're looking for symptoms of hepatitis during that monthly visit and any other side effects the patient might have. So if you have elevated LFTs, the first thing you want to do is try to figure out why. And some elevation is probably relatively normal, actually.
Yeah, it's pretty common with INH. It's probably 15 to 20% of people, if you really monitored them closely, you'd see some elevation. But most of the time it goes away with even continued treatment. So you just treat through it.
Treat through it, yep. Another common problem is GI complaints. Just be kind of aware that these are the same symptoms as liver toxicity. So, you might want to get LFTs and make sure they're doing okay. If everything's cool, I don't know what you usually recommend if people are having GI problems.
Yeah, I mean, usually the GI stuff we see with rifampin as opposed to INH. I usually recommend them taking with food instead of an empty stomach, and that usually helps.
Mm-hmm.
It does decrease absorption a little bit, but as long as your urine's still changing color, I think they probably have adequate levels. So I have them take them with food. It's amazing the difference. I mean, it's a night and day difference for a lot of people.
Okay, rash. Here's a couple things for dealing with rash.
Yeah, antihistamines, sure. Skin hydration, sure. So, I mean, if it's a local rash, you can put local prednisone on it. I mean, if they're really having a drug rash, it's pretty tough to. It's pretty tough because it's going to get worse. You're going to have to change your therapy. I mean, occasionally I've tried it, and it works. I mean, I put people on prednisone to get people through it, and hopefully they can stay on their drugs. Sometimes that works, sometimes it doesn't. So, you just have to look at the extent of the rash and if it's progressing. But if it's pretty extensive and progressive, you're just going to have to stop the drugs.
Okay, peripheral neuropathy. Hopefully most of us aren't using too much INH anymore, but it's really related to the INH. If you didn't have them on vitamin B6, that would be a good thing to try. If it's not tolerable, just switch them to one of the rifampin.
Yeah, we don't see it much because everyone's on B6. So.
Yeah. All right, completing treatment. So you're always going to have patients who miss doses, and you just want to really make sure that they can commit to the treatment and look at their barriers. I usually say if the interruption in treatment is longer than 2 months, you need to rule out TB disease and restart. I don't know what you think.
Yeah, no, I think the 2-month rule is right on. That's what we use. So
yeah, an occasional missed dose isn't a big deal. You just kind of throw it to the end of treatment to finish it up. So this is sort of the completion table here. You want to give the patient a completion record and congratulate them when they're done. So they need to keep that record, otherwise they might end up getting treated again somewhere else.
In fact, everybody I treat, it's probably old school, but I give them a completion letter, and they can just put it on their computer or in their back pocket, whatever they want with it. So if anyone questions them ever in the future, they can refer to it, or at least call us up, and we have it on file. We can send it. So
yeah. Okay, so just a couple FAQs here, and then I think we're almost done. What happens if somebody refuses LTBI treatment? Nothing. Sometimes people ask me that, but
yeah,
it's okay. You had a patient that left unexpectedly while on LTBI treatment. She's been gone for 3 months. What would you do typically?
Well, you'd have to restart her.
Yeah, restart.
Yeah, as you say there, if it's longer than 2 months, we usually kind of restart the treatment. So
yeah. So this has happened a couple times in Oregon where the pharmacy didn't have rifapentine and then the patient accidentally took INH weekly for a month. The patient, say, was supposed to be on 3-HP. What would you need to do? You need to start over.
Yeah, you probably just have to start over. I mean, I don't know how rifapentine alone works once a week. It certainly works better when the INH is there. So, I mean, whether you could give them, credit for a month using one of the drugs alone for a month, I don't think you really can. It's not the same kind of credit. This person took INH, I guess, for a month, but only weekly. I don't know. I don't know how to give any credit for that. That's too nebulous. So you'd probably just end up saying, well, sorry, good job, and you're tolerating it, great. I'm adding the rifapentine now, and you got 12 more weeks. That's what we do. The other thing is, sure, you could switch to INH rifampin for 3 months or RIF for 4 months. You could do any of the regimens, but anyway, the person's not going to get credit for the month. So.
Okay, another common question. If I need to change regimens, can I count some doses?
Yeah, I mean, I kind of consider 3-HP weekly for a month. That's just as good as taking rifampin for a month, I think, if not better. So usually I have these people, they've done 3-HP for a month or 2 months, and for whatever reason they can't continue, then I just continue them on rifampin alone for 2 more months. So I think that those, you can give that kind of credit in this case.
Cool. Can somebody develop drug resistance TB by taking LTBI treatment inappropriately? I think the answer is no.
I mean, only when they don't have LTBI.
Right.
We do see that sometimes that they didn't get, I don't know, they didn't get an recent X-ray done. It was from a year ago, or and now they actually have active TB. So it's unusual, but it does happen. But again, it only happens if they don't have latent TB. So.
All right, I think that is about the end of our presentation here. Here's some links with a bunch of resources for you guys. And this is my information and also the information for the Curry International TB Center. You can get consultation through them as well, or through us. And let me see if we have any other questions here that we haven't answered. All right. Why is a person with greater than 15 millimeters in duration unlikely to be infected? Right? Am I reading that right?
Yeah, that is what it says. They are likely to be infected.
Yep.
Definitely. I mean, the bigger the duration, the more likely it is to be true.
Correct.
They're just, Heidi was just making the point that if that's the threshold you're using, they have, that's the threshold we use in people who have no risk factors.
Right.
Because it's so big that we don't really care about their a priori probability. Exactly. It's likely true.
Yep, exactly. Okay, for the new 3HR therapy, how often are you recommending follow-up and monitoring? So I think it would still be a monthly visit, right?
Yeah.
For the 3 month INH.
I do, personally, I do every 4 to 6 weeks. I mean, I think the guidelines would say every 4 weeks. Just like you were using INH for 9 months, it'd be the same idea. And, that should be an assessment of how they're tolerating the therapy and, signs and symptoms of active TB or, LFT monitoring if they need it, like if they have a priori elevation or, elevation of LFTs before starting therapy, or if they have other risk factors for hepatotoxicity, then you'd want to do that monitoring, just like you did 9 months INH.
Perfect. All right. Any other questions? Throw them in the question box there. Otherwise, you can certainly email me and we'll answer your questions by email. So if no more questions, I think this concludes the webinar. Thank you, everybody.
Thanks, guys. Good luck out there.
Yep, good luck out there. Stay well. Talk to you all soon. Bye.
Cheers.